Thanks for coming to our session, Creating Actionable Information for Healthcare Professionals and Patients to Enhance Outcomes. If many of you were here this morning, you heard one of the speakers say it came up a couple of times, kind of hate that word patients because we're people, right? And I'm talking about all of us in the room. We're people. Sometimes we just happen to be patients, but we're really just people trying to live our lives the best and the most healthy way we can. And when we get sick, we just want to get better. And so we're just going to try to reframe our thinking a little bit, moving it away from patients and basically make it more about people and putting people in the center of healthcare. I'm Lorraine Chapman. I'm Senior Director of Healthcare Services at Macadamian. And I'm going to introduce our panel and then just give you a little bit of an overview of what we're going to talk about today. I'd really encourage people to ask questions as we go along. I don't know about you, but I hate waiting until the end to ask a question because then sometimes I forget. So if you have a question based on the discussion, please just raise your hand and we'll get a mic over to you and we'll just ask it in the moment. And I'll leave some time at the end for people who don't feel comfortable doing that, and we'll ask questions at the end as well. Okay? So I'm going to introduce you to the panel. So we have Bridget, so I'm going in the order that I have here, but not necessarily in the order that we have people up here. So Bridget Hurley, who's at the end. Bridget is the VP of Clinical and Regulatory at Evidation Health, a digital health company based right here in San Mateo. Evidation quantifies real-world outcomes and product impact in the digital era using data from wearables, apps, and connected devices and populations at scale. So you probably just figured out I'm Canadian, so there's going to be a few words: data, process, all of that stuff, just warning you. Bridget has over 18 years in medical device product development and was based in Brussels for 5 years as the head of the international clinical ops for Abbott's vascular business. So she comes to us with a great background in this particular space. Then we have Amanda Goltz. I'm right here. Amanda is based in San Francisco and leads digital health innovation and investment for BTG, a $3 billion British-based pharma company with a strong presence in cancer. Past roles include innovator and entrepreneur at Aetna, Pacific Business Group on Health, and health IT consultant for the state of California. She's also created digital report cards for quality and safety measures at Partners Healthcare in Boston. And Amanda's on the board of Oncoverse, a Dignity Health-created digital virtual tumor board incorporating patient life circumstances and treatment planning. That was a mouthful. And last but not least, we have Martha Najib. Martha is a high-performance, award-winning VP of Business Development at Ximedica with over 15 years of groundbreaking achievements in sales and marketing, global strategy, and commercialization in healthcare, life sciences, molecular diagnostics, genomics, and digital health with industry leaders such as Siemens, Abbott, and Roche, and I don't know how to... Cepheid. Thank you. So I just gave you a little bit of taste of who's on our panel. I'd like to get a sense of who's in the room with us. Anybody here who are physicians or clinicians practicing? Yeah, great. Any investors or venture capitalists here? Yep. Pharma, anybody from pharma? One. Payers? Great. And software developers, people working at companies who are producing digital and connected applications. Great, awesome. So we've got a good cross-section of people here. That's fantastic. So I'm just going to open things up by, I read you their little bios, but I'm going to actually get them to talk just briefly on what it is they're doing right now, specifically in their companies, and then we'll start the discussion. So we'll start with you, Amanda.
Sure. Hello, is this on? Yes, it is. Hello, everybody. Thank you for that introduction. That was great. I need to cut down the number of words in my bio for sure. That was a lot of words. So, as mentioned, I'm Amanda. What I do for BTG, which is a global med device with a specialty pharmaceutical portfolio as well, and we are very active in interventional medicine. primarily oncology, vascular, and pulmonology. And what I try to do from the digital perspective is gather, index, or even create new sources of data that give us information about the outcomes of our products, give us information about what happens to the patient before they even need our product, so that we can think about that patient journey. And so you're starting to see where some of the big advantages come in from real-world evidence and some other sources of data that are beyond the scope of our clinical trials that we're only able to get by looking out into the broader world. And I also try to create not just point solutions, I think we've had that in digital health for several years now, but platforms, things that make sense out of the data and then tell us what we should do next. Maybe that's around commercializing a product or working with the physicians who treat our patients, but it also could be information about how does this treatment pathway stack up against all possible alternatives? Is there a way we can personalize the selection of that treatment pathway to the particular type of patient, right? So that's a kind of personalized health, not necessarily precision health, although genetic data is an incredibly important piece of that. But what's right for this patient based on their clinical presentation, on their medical history, and then on their biopsychosocial circumstances, the social determinants of their health. Mm-hmm. And so if you think about this, this is a really, really big and exciting data project, right? So how do we work together? How do we pull the data together? And then how do we weight different types of data so that the important stuff shows up to the right decision maker in the process? So that's the sort of essential puzzle, and we're taking little bites at that through a bunch of different sort of attempts to build something that will be reproducible and useful.
Great. Martha.
Great. And hi, I'm Martha Najib. And as Lorraine had said, I have come over from the other side of the industry. So I was with Siemens, Abbott, Roche, and just recently Cepheid in sales, marketing, and global commercialization. I now work for a company called Ximedica, the business development. Ximedica is a great company. We develop medical devices from concept to commercialization, including all the IVD regulatory considerations and some manufacturing in the ISO manufacturing. One of our, I think, biggest strengths is we've been doing medical device development for over 30 years, so we understand not only the FDA considerations, but also the commercialization, who the customer is, who's going to be using it, who the buyers are, who the decision makers are, and we are pretty successful. So we do both medical devices and diagnostics.
Great. Bridget.
Great. So my name is Bridget Hurley. So I work with a company called Evidation Health. It's a company that's really looking at how do you take everyday behaviors, looking at connected health populations, and apply that so you can understand and maybe better characterize both data as well as patient populations to improve health outcomes. So a lot of that really boils down to, we do kind of traditional, what you would expect in a traditional clinical trial, but using a virtual online platform. So patients are engaged through a digital platform, they enroll into a study, they consent, and then essentially they connect all their various digital streams of data, as well as we would take some contextual data, behavioral data, environmental data, so looking at anything from pollen count to weather, and overlaying that on the patient's experience, either working with a device or it could be a medical health app, digital app, or pharmaceutical agent. Like really trying to understand what are those signals that you can see in the data that would point out what types of populations should either receive a therapy or what would be maybe a super responder to a therapy, and really trying to understand at a broader level than just those episodic events at a clinical trial.
Great. And so, I mean, there's a common theme here, data, but also what to do with that data. And if everybody was around for this morning's panel discussions and talks, and one of the things that I loved about it was that they were talking about data, but then what are the different components outside of just that pure data? That can help improve people's lives, right? Because information isn't enough, and I think we all know that we can provide a ton of information to every single person out there. It's not necessarily going to change outcomes. And so I'm going to start with a personal story because I think people get into this area because of personal experiences and personal stories. So my father is a heart transplant recipient. He had a massive MI at a very young age, 47. And had a heart transplant, was in and out of hospitals for many years, finally had a heart transplant about 14 years ago, almost 15 years ago. So he's doing well, but in my experience as part of his care team, a care partner, I saw a lot of information being put out there and nobody really acting upon it because they either didn't know how to do it or there were other factors at play, right? So some of it social determinants, some of it addiction. So my father was in the Heart Institute, and every day I would walk in and out. I'm from Ottawa, Canada. So the Heart Institute is world-renowned. Every day I would come in and out to see at least 10 patients holding onto their IV poles and smoking. They're at the Heart Institute. There is a reason why they're there. Presumably they've been provided with a ton of information, but for whatever reason they're unable to act upon that information, right? Smoking is an addiction. It's a powerful addiction. And so what are some of the things that we can do to really turn it from just, not just data, but taking into consideration other elements and other factors to really change behavior. And that's my background. My background's in user experience, and we design and build applications to help improve outcomes or just make lives more meaningful for people. And Amanda was kind enough to share this article with me that I hadn't read until she shared it, by Mark Bertolini from Aetna CEO. It was an interview, actually, and if you're interested in reading the full interview, come see me afterwards or come see Amanda, we'll give you the link. But basically, he points out that all this time and money is being spent on something that really impacts our personal outcomes by maybe, I think it was 10%. Yeah, 10% of one's life expectancy is determined by the clinical care they receive throughout their lives. And that's where we spend $3.2 trillion a year. And they represent a very small portion. Yes, they cost us a lot, but they represent a very small portion of the population. 20% is related to social determinants, the environment that you're in. 40% is related to behaviors which are driven by your environment. And 30% is related to your genetic code. And so your zip code, where you actually live, actually has more to do with your life expectancy than your genetic code or any clinical care you receive. So just think about that for a moment. So something's broken. So what can we do about it? How can we really effectively impact those outcomes by taking a full, holistic view of things and incorporating it into, either your clinical care or your software product development, what have you. But that's really about the topic of conversation today. And so I'm going to start with a very broad question and present it to all of to each and every one of our panelists. Some of those factors is about meeting people where they're at, right? So they may not be sick. Could be me leading a healthy life. What are some of the things that I need to be aware of? How can you improve and impact my life? Right down to the polychronic patient. And so some of those considerations are going to be different for a polychronic patient. What can we do in that sphere as well? So simple question, but a complicated answer, I'm sure. So how do we meet people where they're at in their life context?
So I think this is going to sound like a wishy-washy answer, but it's really down to that personalization factor that I talked about before. You have to figure out what's important to them, and for some people, health is not the most important thing in their life. So when we were working on Omniverse, for example, what we were trying to do is relay pertinent, actionable data on the patient's life circumstances in the tumor board setting. So a bunch of oncologists sitting around trying to figure out what the right treatment pathway would be for a patient. The patient is not in the room, right? This is a very high-level clinical discussion between specialists. But what information would they need to know about the patient that's not reflected in the clinical record to make those decisions? And that can be things like they live more than 200 miles away from an infusion center. So it's very difficult for them to get there. So maybe you do oral chemo at home instead, right? Or maybe they are 92 years old, live at home alone, and have dementia and have fallen twice in the last month. Maybe surgery is not the best option. Tumor is operable, but maybe it's not the best choice for that patient, given the likely adverse events that could occur. So we were trying to think about that, and what we found when we collected that information is to design a survey that the patient could do. And as I was developing those surveys with patient communities online, what kept striking me again and again is that the questions were not about medical care. They weren't even really about health status, right? They were really about who's going to take care of my kids, how am I going to get the time off, insurance status, insurance status, insurance status, of course. But people tend to be very oriented to how it's going to affect the people around them, right? I'm sure they have all kinds of psychological response to the fact of being ill, but that tends to be a secondary consideration to how is this going to impact my life, and your life is mostly made up of the people around you, right? So when I think about that, I wonder if the way into that is really through the social connections, not just in the way that we understand, we've thought about how good behaviors are social, right? They sort of like network out. Like if you're friends with people who smoke, you smoke. If you're friends with people who don't smoke, you don't. It's not so much that, so much as I think if you're asking somebody to do healthy things, don't ask them to do it just to be healthy on their own. It's very virtuous, but I don't know how effective it is. Ask them to be healthy for the people in their lives. I think that would really work. And we need to connect that with better data to say every day you don't smoke, you get to see your grandchildren one day longer. Or like something really dramatic and soap opera like that. And I think that would be really good.
It's like, so we're working with a client right now who is focused on cancer care. And they're doing something similar. So understanding, let's say it's a 45-year-old woman with breast cancer, she's got 2 kids, she wants to continue working, and so what's important for her is managing the symptoms, right? And so if you can provide a reason to track those symptoms so that an intervention can be provided earlier, so that allows them to look after the children and continue working. So that's the type of interventions and designs that you're talking about.
Exactly. So it's not just about disease progression or extension of life. It becomes about the treatment that fits best into your life. We have the data to do that. Yeah, exactly. We're just not using it.
Yeah, I guess I would add to that in the sense of as you look at the data, there's a big piece of what we would call sort of turning the lights on below the surface of those episodic events and looking at what other data could you see that could be taken passively. So rather than just collecting symptoms, it's also looking, can you see something in their sleep data or any patterns of going in and out of the house that says perhaps their symptoms are getting worse, but someone does need to intervene and either provide education or provide necessary support to allow the kids to get some sort of service while mother goes for treatment. So I think there's some aspect of how can you collect that data to then impact that patient at the right time, wherever they are in their life.
And that's what you refer to as real world evidence, right?
Yeah, for us it's everyday behaviors. I think the real world evidence is what the FDA is looking at, but it's much more than just the clinical data.
Right. And so can you talk a little bit more about that and being the ability to connect the real world data with clinical data and other forms?
Yeah, I think, again, that's where we're really trying to see where can you see using more traditional clinical endpoints. If I take a diabetic patient population, we did a study where there was using a diabetic coaching app. And in that group, it was really looking to see, could you impact their A1C levels? But underneath that, it was really saying, when is the right time to give them information? When is the right time to coach them based on either what they ate that day or what type of activity they did or how their sleeping patterns were, so that you could actually make an impact. Just giving people information is not necessarily something you're going to act on, but it's understanding when's the right time based on that person.
Martha, do you have anything to add to that from a diagnostics perspective? Or?
Yeah, so I can add a little bit on what I think is really clinically relevant information. So to me, clinical versus wellness. So clinical to me is if someone has either an acute or chronic medical underlying condition that they are dealing with. So from a clinical standpoint, I think there's 3 distinct categories of relative information for clinical. So the first is actually an outlier that would require your physician to intervene. The second type of classification is actually patient. So information that a patient would need to respond to in order for them to manage their condition. And the third is really preventative, which is a lot, I think, of what we're saying up here as far as bringing all that data and making it make sense. But you really need all three to make an impact on a patient and really start to contribute to personalized medicine.
So you have a good example of that. Can you tell that when we had that discussion?
Yes, of how I've seen it done best. So first, let me say, with just the physician information alone, I think there's three directions you can go. It's either no response, changing or altering the treatment, and/or consulting with the patient. For patient response, I think for patient response, it's so 100 million Americans are either diabetes or pre-diabetic in the U.S., which makes up for 94% of our population, which is really big. So in the second category of the patient responding, we're seeing all this amazing innovation now of biosensors that are sitting on the skin that will now start to do some of these pre-episodes. And so it would say, okay, Jane has diabetes, and now we're seeing that her insulin is low, but we know she just took her medication. What can we prompt her to do? So that's where the patient needs to do something to help their medical condition. And the third is preventative, and that's where, you know, you're diabetic, and we all know that if you're diabetic, you're at high risk for heart disease and stroke. So it would be going to Walgreens or going to the pharmacy to get your prescription, and maybe your coupon coming up that a low-sodium snack might be better, or maybe based on your heart rate or your wearable, they're recommending a shower chair because they notice that your heart rate goes up when you're in the shower. So I think it's really integrating all of that, but the difference between clinical and wellness is clinical, you're actually combining all those factors and those categories to help someone's underlying condition.
So can we talk a little bit more specifically about the social determinants of health and how we can, because I mean, as I outlined in the initial, the quote from the initial interview, we're really not making use of that data. We haven't figured out how to marry that with the traditional clinical data that we're looking at. I mean, even today, many of you have probably been to so many different conferences, and I keep hearing we have too much data, and often practicing physicians and clinicians say, you know, I don't want that Fitbit data. I don't want this, you know, your fitness. It's great that you're keeping track of your steps, but that doesn't, clinically, that may not have any relevance to me, right? So they're worried about being overloaded. So how can we now add another component, which absolutely we should be looking at, and making it meaningful for both the clinician, the health, you know, the health provider, as well as people.
See, everybody's looking at me because they know I'm going to say something controversial, which I totally will. So I think the problem is, if the doctors don't want the data, don't give it to them.
Yeah.
They're not going to do anything with it. They don't want to do anything with it. It's not their job. It's not why they went to medical school, right? They went to medical school to cut people and then like put stuff in them and take stuff out. I mean, don't ask them to solve educational demographic problems. It's an unreasonable ask, and it's not the highest and best use of their time, frankly. So I think as more and more risk-based contracts start to come down the pike, as more and more providers start seeing the pay provider, right? A provider who's at risk on outcomes, or a payer who's now delivering care, as we're starting to see with some M&A activity in the space. As soon as you're responsible for outcomes, it's suddenly in your economic best interest to provide those services, right? That do make sure that the reason the patient is coming into the emergency room all the time with an asthma attack isn't that they're allergic to their own carpet. And if you just switched out the carpet, you'd have many fewer hospitalizations. Or, my favorite of all possible examples, you know, there's a non-de minimis amount of money that New York Medicaid, so I was in New York for a while, I know I should look up California so it's more relevant, but actually, no, because it doesn't get hot enough. But so in New York, it gets very hot during the summer, very hot, sticky summers, right? And Medicaid spends a huge amount on patients with heart failure, Medicare and Medicaid both, who come into the hospital all the time when it's very hot out. When it's hot, they have to sweat, their heart's laboring, right? They have heart failure, so they're already sort of struggling. If you just bought them an air conditioner, you could cut those costs by like 80%, right? But an air conditioner is not a medical device, so Medicare won't pay for it. So who would be responsible for buying that patient an air conditioner? And as soon as you have a provider that's under risk, it starts to make sense. So what I'm trying to envision here is a group of people, we do some of this now with nurse navigators and with social workers, but thinking about expanding and enlarging, right, that capability, and then giving them the data so they're able to go do these sort of like community-based personal interventions. The pharmacy will be another great place to start to do a lot of work like that. So, you know, I think we can never have enough data. We do have to make sure it goes to the right place, and we have to make sure those economic incentives are aligned so that it is returning dollars back to the doctor's pocket, but probably by improving outcomes, not by paying them to provide services they don't want to provide in the first place.
Yeah, I guess I would take it from the side of saying, you know, there are a lot of digital apps that are coming to market for you know, various different things that need to actually show the value of them, right? So just having an app or just having some application doesn't necessarily mean that someone's going to pay for it, and I think that's where we have to have, the data is not just to provide data, it's data that actually says when you use this product in this patient population, it does actually improve health outcomes. And it's understanding which patient populations it does work in. And I think that's where we need the studies done to show that certain products will have an impact. And therefore then payers should pay for it, right? But or out of pocket, right? I think we're all going more and more towards paying out of pocket. So what am I going to pay for? It's going to be something that does provide value. And I think a lot of different technologies there have a lot of promise, but just having a product doesn't necessarily mean someone's going to pay for it or it's going to actually have some type of improvement into the system.
Sorry, did you want to add something?
Yeah, and I think, you know, the model that I've seen work the best, where it really integrates both the clinical and more of the behavioral, is really in the bariatric community. So I have a friend who's 200 pounds overweight, and he attends a bariatric center near Indianapolis. And to me, it's really fascinating and comprehensive. So he has a medical doctor that takes his blood, knows what prescriptions he's on. He has a registered dietitian that works with the medical doctor. He has a psychologist, and he has a physical therapist that helps. So obviously he's on Coumadin, so he can't have leafy vegetables. So the dietitian works to figure out what alternatives. They found going there with his blood, he now has an irregular heart rate, so they have to work with the personal trainer to figure out what can be done as far as exercise. The other thing that would be great to add to that is really the data that both of you collect of, you know, that to me is where a wearable makes the most sense of, you know, how to make better decisions when you're going places. Not better decisions, that's really not fair. How to know what is a good choice for you based on your condition. So that is the model I've seen work the best, and I think
I'd be interested to see if anybody in the audience is starting to incorporate some of this stuff in any of the products that they're developing or services they're providing. Yeah?
I heard an awful lot about doing to people. We get lots of data and we failing to you. I would like to suggest that if we really are going to solve solutions, we got to do with, not to.
Right.
And that means that the patient, the client, is part of the solution and not the object. Mm-hmm. Yep. And all I've heard today is patient as object. And there's a very large difference. There's a film that I recently saw at a very large tech conference that I wish you all could have seen, but I'm going to describe it. It's an older man in England. He has a cane that tells the computer whether he's walking or not. He has a fork which tells the computer whether he's eating vegetables or not. Yes. And so what he does is he gets a young friend to take the cane out walking. And he proceeds to stick the fork into the vegetables and throw them off the plate. And ultimately, he totally defeats the technology because it doesn't fit his lifestyle. And that's where I'm very, very concerned about all this doing with, and doing to instead of doing with.
guys like to respond?
Yeah, I mean, I think that's an excellent point, right? It's how do you engage the right person? Yeah, no, I totally agree. But I think a big part of, a place for Evidation is that it's an online platform that at the end of the day is entirely voluntary, but I guess what we found in general is that people want to participate in research. People want to understand more about conditions that they have and understand how that can potentially help that greater population. So I think, what we found, at least when we look at running a study, if you compare it to a traditional study, typically, at least my experience with medical devices, you have usually 10 to 15% women in a trial. You don't. It's typically a very, I would say, a very, pure group of participants that are coming from a radius of 25 miles around a university center. When you go out and do virtual studies, we just published a study that was in a group of patients that was 70% women. It was 45% didn't have a college degree, 25% were either African American or Hispanic, and I think that was not by design of the study. So I think there's an aspect of we really have to run studies that represent a much broader population and engage people to participate in the process.
Yeah, I just think that's so right. I mean, that's what we did in Oncoverse when we were building the survey. We didn't say, doctors, what information would you want from the patient? We didn't ask the patients, what do you want to tell your doctor? We just said, what are you worried about most with your cancer treatment? What don't you want to do? What can't you do? What would you do if we gave you some help? And we didn't medicalize those answers. It was whatever it was. I need babysitting, I need gardening, I need transportation, right? I mean, and those were the answers that came up way more than I would like this brand name drug at this, amount, please, right? And I think that's really critical. I think what we need to do a lot more work on is make that matter in dollars and cents to the people providing care. We've got to figure out that mechanism, because right now, you make the most money off of doing maximum amounts to every single person who comes in the office. And so we got to figure that piece out.
So balancing, as she pointed out, balancing the needs of the person, so identifying what their specific goals are, what they want to do. Because in that particular example, and thank you for that example, because it does speak to not just ability. So clearly, in that case, he had the ability, right, in that video. He lacked the motivation, but why? Right? Is it just that, well, I really don't care about this. I want to be able to do X, Y, and Z, not A, B, and C. And so being able to also understand we have this information and understand what their underlying motivations are, and not just their abilities. At least we're starting to think about their abilities, right? Being able to get to an appointment or being able to walk around the block, but also the motivation to what's going to motivate them to continue doing it. Is it I want to experience less symptoms so that I can look after my children or what have you. And one particular study that we did was with a remote health. It actually started out as a medication adherence tool using voice. So an echo, a customized application of it was put in. It was to assist people to live independently in their home, older people, and mostly around let's tackle the medication adherence part of it. In the end, it did that. It did show some promise with that, because it didn't rely on somebody triggering it. It actually triggered. It said, it's 9 o'clock in the morning. It's time to take your medication. It would seek to have that two-way conversation. Did you take your, confirm. Now, there's nothing to say that they didn't just pour the pills down the toilet or what have you, but the side benefit was actually the connection, because they're living by themselves in their home. And so it would also ask them how they're doing today. So, if somebody let's just use my name, Lorraine, how did you sleep? Well, actually, I didn't sleep very well, and I'm feeling very depressed. And it could actually provide the mechanism to reach out to their son or daughter, for instance, to make that connection. Your mom's having a bad day. Give her a call, things like that. I know I had, yes, thank you.
Hi, I'm Arthur Keller with Psychoanalytics, and one of the things that is in between dealing with physical and medical stuff and social determinants of health is behavioral health. And so part of the issue is that primary care physicians typically, somebody comes up and says, I'm depressed, or I'm not feeling well, something's going on. They typically diagnose anxiety as depression. And the people who are actually depressed don't actually say anything to their client. And so what's necessary is actually to screen for behavioral health issues when the person comes in for a well care visit, or a patient comes in for hasn't been there for a while, to screen for that, and to try to give some information to the doctor as to what's going on. And so the thing is that behavioral health issues can be something the doctor can act on or refer into clinic or whatever. When you get to social determinants of health, there's not that much the doctor can actually do. It's more of the system. It's more of the clinic overall. It's not going to be done by a doctor. It may be done by, as you mentioned, a social worker or things like that. So I think that's I think, because there's a lot of comorbidity between chronic conditions and behavioral health conditions. So we're actually doing the screening for those behavioral health conditions in primary care settings. So that the doctors have actionable information and decide, well, this person should be referred or should not be referred, or this person is suicidal and we didn't realize that, at risk for suicide ideation, and we need to deal with that. And so the PH29 is not enough. We need to have actually a broader-based screening.
Great. So thank you very much for that. But you also highlighted something, and I wanted to see what the panel thinks about this. You made the statement that the providers, physicians, can't do much about the social determinants of health. But is that true? I don't know. Like, that's a challenge to everybody else. Can we make changes in the system to accommodate those things? Anybody want to? Anybody in the audience want to? Yeah. Can we get a mic up here?
Yeah, I would like to answer that question that you asked.
Okay.
So
you can answer right after we're done. Go ahead.
Okay, thank you. So just a couple of things that I had heard. When we're talking about social determinants of health, those are directly influenced by different forms of structural violence, like policy, right? Like the war on drugs policy, the 3 strikes policy, the different policies that this administration is putting forth right now. So unless healthcare providers are able to strategize and address policymakers like, hey, yeah, you may want to pass these policies because of the money pockets that you're beholden to, but this is what it's going to cause long term, nothing is going to change. And then also, what can providers do? We have to address our internalized bias, right? Because patients, why would I want to come into any medical facility? It doesn't matter how good my healthcare is if you're going to be judging me and treating me like I'm less than human because you have your own things going on there. Mm-hmm. So when we're talking about data and what can we do with the data, I think it's less about the data and what it can do, but it's what is the story that the data can tell in the qualitative end. So I really encourage people, there is enough data. We've done all these research studies in terms of what's going to really address health issues in our community. And we have to start addressing the social determinants of health from the structural violence point. And we also need to start talking about intergenerational trauma. That's the root foundation of all chronic illness. So all these different technologies and these little pills and all these little VI and AR or whatever, that's not going to work because you haven't addressed the root problem, which is the intergenerational trauma, which is created by the structural violence. So here we have the double whammy here, right? So a lot of us sitting here in our positions of power, we are directly responsible for creating some of this trauma, right? Because of our internalized bias and how we treat these different populations. Mm-hmm. So I just wanted to put that out there coming from the public health background.
Fabulous. Thank you. Thank you very much. Go ahead.
What I wanted to bring up is that a lot of the things that we're talking about really require a social interaction model. So, for example, I'm supposed to go take a walk, but I want to take a walk with somebody. Mm-hmm. So now on my own, I need to run around and find somebody who wants to take a walk with me when I'd like to take a walk and where I want to take a walk. And it seems to me that putting effort into what I would call our circles of interactions makes a lot more sense, because if we can get me together with 2 other people who live in my neighborhood and we even walk just around the block together, we have created an environment that encourages more exercise, which presumably we all need, and which will affect the data you're talking about, because it's going to affect the diabetes and the blood pressure and all of those other things. And I think that we're at a disadvantage in the healthcare umbrella if we are not working to create what I would call circles of interaction, so that people go ahead and take the walk that the doctor said to do.
Okay. So I heard a couple of things. So one is tearing down existing structures, for lack of a better term. I'm trying to capture what she said, right? Ones that are biased and might impede somebody's ability in a social, in a cognitive way. And then what you're suggesting is creating, and it may be facilitated by technology, but creating these other social infrastructure to help support some of these behavior changes. Would you guys like to comment on any of the points raised?
Yeah, I'll comment on that. So I really think that a lot of the behaviors that social media and the apps from the consumer world that are out there now. So for example, Facebook, there's people that like to play games. That's a whole motivation there. There's people, like you mentioned, that want to meet up. I've heard of companies that will incentivize their employees with financial rewards if they sign up for a health plan or if they walk more. And so I think a lot of our behaviors and what motivates us is probably mimicked by how we utilize our own phones, whatever. So I think probably a lot of those concepts are already being done in the consumer world, and we probably need to bring them over into the healthcare industry. But I'd like to know what both of you think, coming from your background.
Yeah, I mean, I spend a lot of time wondering if I'm part of the problem, right? So if I'm walking around all the time complaining that healthcare is artificial, it's an artificial construct, right? Everything you do in your life, your environment, everything that you interact with, the air you breathe, the food you eat, the family you come from, the place you are, affects your health. And I'm making technological solutions to try to alleviate some of that, right? Mm-hmm. Am I medicalizing things that shouldn't be medicalized? Mm-hmm. Are these greater policy issues that you get way more bang out of your buck in terms of quality adjusted life years or whatever your measurement is by addressing those policy issues than constantly returning to the medical solution over and over again, even if you dress that up in a cool digital covering? So I think about this a lot. I mean, you can only do what you can do. I think that recognizing how the institutions all lock in together and how everything is intersectional is critical. I have a particular set of knowledge and skills around healthcare, so I try to direct my focus where I can be most useful and then keep my eye on the intersections everywhere. I think a lot of this, what we've lost sight of, because we're overcomplicating it a little bit, is that it's matching up supply and demand, not to be all free market about it, but I really do think that's part of it. Mm-hmm. If you think about the successes of some of the technological revolutions that we've seen, Uber, Airbnb, et cetera, people need a thing. I need a car to get to a place, and I don't have one. I need a place to stay, and I don't want to pay for a hotel. There are people who have cars they're not using and homes they're not using. Match the two together, there you go. There are people who should go to the walk that their doctor told them to go to, but they want to walk with somebody. There's somebody who would walk if they had somebody to walk with. How do we bring those two together? So I'm wondering if, we started out talking about data, and I think that's great, but I wonder how we could use technology to bring those two supply and demand pieces together. Mm-hmm. How, if somebody's really looking for a guide, they can get that guide. If somebody's looking for a mom to nag them about going to McDonald's every day, that's the thing they can get, right? And I wonder if there's a way to use our social networks and to use our institutions to bend that direction.
Mm-hmm. Yeah, I think just an added piece to that is understanding what motivates that person, right? Is it just meeting up with someone? Is it meeting up with someone that has a specific interest, right? And that's where you still have to get at the heart of what motivates me to do something, right? And what would help me do that? It might be a technology tool, it might not, right? But I guess when I think about it in a healthcare vein, it's also looking at that full ecosystem to say, how do we have the right behaviors or how do we have the right metrics that drive the right behaviors, right? And so physicians, I think, are an aspect of that. They have to help ensure that that patient's getting the right feedback, and what will it take, understanding more for that person, what will it take and how will they engage, right? And I think that's going to be different for every single person.
So again, meeting people where they're at, right? So again, I'll just use myself as an example. I don't have any health conditions, and I say that and go, oh, what, except I have asthma. And I'm also a runner. So what if, when I get Alexa to start playing my favorite radio station in the morning as I'm getting ready to go out for a run, it could tell me, hey, high Humidex today, Lorraine. Take your inhaler before you head out for that run. Things, and I think those are very simple mechanisms that aren't, again, it's just me. I don't think of myself as a patient just because I have asthma, but it could also be applied to different, chronic diseases in a variety of ways, but it fits specifically into my lifestyle. That works for me because I've got an Alexa in the home, but again, finding other mechanisms depending on what demographic. I love that discussion this morning, depending on what demographic you're targeting, and making sure that you're doing it in the appropriate way. We have like 2 minutes left, and I love this conversation. So if anybody else has any other questions, we'd love to take more questions from the audience. Anything? Anybody? No? Okay, well then I'll finish it with one last question to my panel, and that is, what's one thing that you would, in the room, want people to take away from today's discussion? Just one thing for them to think about.
Oh, I think we'll probably all say something very similar, but I guess for me, again, I am working in the clinical trial space, so I guess for me it's really making sure that everything we design is about that patient or that participant and how we engage them in the process and understand from their point of view what will be engaging and how they want to participate in that process. So it's ultimately for us to understand how we engage better health outcomes, but I think it has to start with how do you engage someone in that process.
Yeah, and I agree. So I come from the product development perspective also, and I would say we get a lot of companies that want to develop a device and bring it into the medical world. And I would say, first of all, really define what disease state you're focusing on. And I think someone in the audience had a great advice earlier of really understand what goes on in the day of life of that patient, in the day of life of that healthcare practitioner and their caretakers, and build your application or your medical device around that, including the 3 distinct classifications, so that you're adding value to that ecosystem versus just adding a wearable that does heart rate. Have it really make sense to a disease state, and I think you'll see the crossover a lot easier.
And we actually didn't talk too much about this, but we didn't define outcomes, and I think it can mean a lot of different things to different people. So my takeaway is let the patient define the outcome, not the clinician.
Absolutely. Great. And with that, thank you very much for participating in the conversation today.